mentioned, I'm a psychologist. I've worked over the last few years in a range of different settings, hospital settings, rehab settings, also with people in their own homes, predominantly after different kinds of brain injury. So I think that hopefully sets us up nicely to think a little bit today about the kinds of behaviours that can sometimes cause difficulties or challenge after brain injury. This is going to be a bit of a whistle-stop tour of a session because it's obviously a really big topic, a really big area. But I hope to just kind of introduce some key principles really that I think can be helpful in guiding the kind of approaches that can be helpful. So first, to just encourage you to think about the kinds of behaviours that come to mind when we think about the word challenging. You know, what behaviours cause us challenge, cause us difficulty, either as family members of somebody with a brain injury, as professionals working with somebody with a brain injury in different kinds of settings. And there can be lots of different things that go with that. Things like disengagement from therapy, impulsivity, aggression, kinds of repetitive behaviour. There can be lots of different things. This is by no means an exhaustive list. But different kinds of challenges following brain injury can make life really stressful and can be really difficult. I think the definition of challenging behaviour is a bit tricky to pin down, but I think generally what we're talking about is behaviours where there is some sort of negative consequence or implication for the individual, where quality of life is affected in some way. I like this definition from the RCP and the BPS, which talks about the impact on the individual as being excluding in some way. It leads to responses from services maybe, or from professionals involved, where there's some impact on the person's quality of life or safety. I think it's also really easy and normal, especially when we're stressed, to think negatively of these kinds of behaviours, and sometimes that can lead to some quite stigmatising and quite negatively framed comments. And I don't know if any of these might sound familiar if you've worked with people with behaviours that cause challenge. We sometimes see quite negative judgments on these kinds of things, which I think can just set us down a really negative path in terms of being able to provide a person-centred and compassionate way to support the individual. So in order to try and kind of come up with a framework to think about this, I think it's really helpful to recognise and to remember that all behaviours for any of us occurs in a context. There are things to do with us as individuals that drive the behaviours that we have, but that behaviour also happens in an environment, and the environment in which it's happening is what will determine whether it is challenging or not challenging. And I'll say a little bit more about that later. But thinking firstly about the kind of the factors to do with the individual, these can be particularly challenging after brain injury, because we know that brain injury can cause a massive wide range of difficulties in terms of physical problems that might involve things like pain, might involve sensory processing issues, it might involve mobility problems, things that can potentially cause practical difficulties, as well as a lot of emotional distress. Speaking of emotional distress, brain injury often goes hand in hand with emotional changes as well. Things like low mood, depression, anxiety, fear, problems with anger or frustration, trauma responses, grief, loss. The list goes on and on and on in terms of the challenges that are often faced by people who've experienced ABI. People often will experience cognitive problems as well. These might be anywhere from very mild to very significant and severe. They might affect things like memory or attention, concentration, thinking skills that allow people to be able to manage challenging situations effectively. And fatigue as well is also worth mentioning. So we don't have a lot of time to say much about this, but for any of us, we're more likely to respond differently in situations when we feel tired or fatigued. The kind of fatigue that is experienced by people after brain injury is often really significant, really challenging, can often drive people's ability to manage situations in a positive way. Again, not going to say too much about this, but I just wanted to kind of, I suppose, identify the complexity of the kinds of cognitive problems that somebody experiences, and I think thinking about that in a kind of hierarchical way can be helpful sometimes. You know, so if I was to, in fact, I might pick on Colin for this exercise. If I was to ask Colin now to wave his hand at me, there we go, Colin, thank you. So I can tell from that Colin is awake and alert. He was paying enough attention so that when I said his name, he tuned in, he listened. Yeah, so that's good news, Colin. That's what we like to see, right? But Colin in that moment also had to process the information that I threw at him. He had to make sense of these funny noises that I was making. He had to process that, think about that. What is it? What does this actually mean? He then had to integrate that with some of what he knew already. He had to be able to then process that and think about, well, okay, how can I turn that into this hand movement? Luckily, it was a hand movement that he's probably done a million times in his life, so it wasn't one that took a lot of thought and concentration. But if it was something a bit more complicated, perhaps it would have been. So as we're moving up this kind of pyramid of cognitive problems, we can see that somebody who maybe struggled with attention would struggle with that initially, struggle with that initial switching on of attention. Someone who struggled with information processing might take a bit longer to make sense of that prompt or that instruction. Somebody who struggled with memory might struggle to be able to link a request to what things they knew already. It might just take more work, more processing. As we kind of get higher up the pyramid, I think it's worth thinking here, you know, Colin, I don't know how long it took you to decide to wave back then, but there was probably a split second where you thought, hang on a minute, is he serious here? What's he on about here? I kind of gave you a problem to solve, right? I gave you something to think about. It was a bit awkward, it was a bit uncomfortable. In that split second, you had to work out, right, well, the best solution here is for me to just wave and then leave me alone and get on with it, right? I gave you a problem to solve. You worked through that problem. That happened in a split second without you really thinking too much about it. After brain injury, that kind of problem solving might not work as well. That might take longer. It might be less effective. So being able to solve problems and then work our way through the best way to resolve something might be more challenging. And then finally, thankfully what Colin did was that he was monitoring as he was doing it. As he was waving, he then kind of was paying attention to me, and then he thought, right, I'm doing the right thing. This is working. I'm going to stop now. And that's really positive, because otherwise he'd probably still be waving now. He was able to monitor. He was able to check, is this working? Is this solving the problem? Yes. Okay. Right. I can change gears and do something different now. So that might be again a challenge for somebody who struggles with that kind of processing after brain injury. So I guess the point I'm trying to make here is that these kinds of difficulties that we see after brain injury can affect everyday simple tasks, and that can sometimes affect the way that people interact. It can affect the responses that people have to different situations that they might come up against. So just as a very kind of quick example, you know, if we imagine somebody who has experienced a brain injury, is in hospital, and as a result of the brain injury, it has some cognitive problems, you know, perhaps tapping into some of those things we were just thinking about. They struggle with being able to pay attention. They struggle with being able to listen to what people are saying. They struggle to be able to remember what people are saying. As a result, we wouldn't be surprised if that person became disorientated or confused. Perhaps as a result of the brain injury, they were more disinhibited or did things without thinking them through. Potentially, as a result, became more aggressive, demanding of the staff that they want to go home because they're not really understanding why they're in hospital or what's happened to them. And that'd be really upsetting and difficult for the staff, potentially also for other people in the hospital as well. So this could very quickly become a really challenging situation. And we can think about the sort of factors to do with the individual there, right? We can think about the cognitive problems and the emotional difficulties that experience an ABI might result in. And that's probably going to leave this person feeling overwhelmed, feeling unsafe. As a result, it wouldn't be surprising that person then starts becoming more verbally aggressive at the staff. They're just trying to solve that problem, but perhaps not in the most effective way. When you mix that in with other cognitive problems like problems with learning new information or poor insight, it becomes even more difficult to then manage. You know, the staff might be trying, they might be saying, look, you're in hospital, you've had a brain injury, just try and relax. It's not, you know, you're in the right place. But if the person's struggling to remember that, that's not going to feel like a helpful way forwards. Of course, we also need to think about the environment as well in that, you know. So in that situation, if the staff members do go back to it and say, you know, you're in hospital, you're safe, don't worry, but that isn't remembered or that isn't retained, that's not going to help. If some staff are saying, look, you need to just chill out and be quiet, or if some staff are just ignoring this person altogether, that inconsistency is just going to drive more feeling, the person feeling more unsafe. It's going to drive more confusion, more disorientation. Also think about your average hospital environment. It's busy, it's noisy, there's lights going off, there's buzzers going off all the time. That when somebody might need that bit of quiet, they might very quickly become overstimulated. It's going to, again, contribute to that feeling of being overwhelmed, anxious, and afraid. It's also a really unfamiliar environment as well. That in itself might contribute to being confused, which might contribute to feeling overwhelmed and afraid. The other point I just wanted to make was about medications as well. Sometimes I think people assume that if somebody is feeling agitated or sort of, you know, feeling upset in that kind of way, we can give them some medication to help calm them down. Sometimes there's a role for that, but we've got to be really careful, because sometimes giving somebody medication to help them to, like some sort of sedative medication to help them feel calmer, might actually dampen down some of the cognitive skills that they're already struggling with. So it can actually leave the person feeling more confused, more disorientated, and it can become a bit of a vicious cycle. So we need to think about the individual. We need to think about the environment, and different kinds of behaviour is going to be appropriate in different settings. As I said before, all behaviour occurs in a context. That context is going to be very different in different situations. Some behaviours are going to be appropriate in some contexts. Some behaviours are going to be seen as not challenging and okay. Some behaviours are going to be deemed as inappropriate in some contexts, and that's often what we'd label as challenging them. What we might do in our own home might be different to what is okay to do in a hospital type environment. The way that I might shout at a referee at a football match might be incredibly inappropriate if I did that in the workplace. Yeah, so context is everything when we're thinking about behaviour. So I guess, again, this is a bit of a whistle-stop tour of a session, but I just wanted to highlight the kinds of things that we might be able to do in those environments, whether we're talking about community environments in people's homes, whether we're talking about hospital environments, rehab environments, supported living type environments. Fundamentally, it's important that we think about the culture of that environment and the quality of the interactions that go on. A lot of behaviours that cause challenge are driven by fear, anxiety, people feeling overwhelmed, people feeling confused and disorientated. So providing a safe base, providing good, trusting relationships with people who can offer that safety and that influence is absolutely key. Sometimes that involves providing some sort of specialist rehabilitation. It's going to depend on the situation. It's impossible to give, things that will always help, but as general rules of thumb, consistency is important. Clear boundaries are important. Making sure that people are on the same page, making sure that people are talking to each other and that communication is working well, making sure that there's structure, making sure that there's opportunities for positive social connections, thinking about stimulation, thinking about when somebody might be becoming overstimulated and need a bit more rest and recovery time, or when somebody might be understimulated and might be really bored, and that might be what's driving some of the behaviours that might cause challenge. Also thinking potentially for some people who are more cognitively impaired, thinking about what we can do to help some of those factors that might be driving distress. So if somebody is struggling with confusion or disorientation, if they don't know where they are and they don't know what's happened, how can we help them to remember that a little bit more? That might be as simple as having some signs up on the wall that says, you're in this hospital on this ward because this happened, just helping to do things, simple things to help support orientation and memory. Fundamentally, though, it's about understanding these behaviours, making sure that we're, however possible, understanding the possible reasons for these behaviours, not just seeing the behaviour in isolation, thinking about what's driving it, seeing behaviours as a form of communication. A lot of people after brain injury might struggle to explain what it is that they're feeling or what it is that they need. So the people around them need to perhaps work that little bit harder sometimes to understand what those reasons are. Sometimes that's not obvious. Sometimes we have to do a bit of guessing, a bit of trial and error, especially if somebody can't easily communicate with us. But I think if we have that as a starting point, as a principle, then I think that sets us down a good path. So again, just for a moment, I just encourage you to think about the last time that you lost your temper, the last time you got upset about something. I won't put Colin on the spot here and ask him to name an example, but just draw a situation to mind. When I think about that didn't just come out of nowhere. It came. There was one thing that happened that maybe pushed it over that threshold where I got really upset. But there were also other things that led to that build-up. Yeah, there were good reasons for why I felt that way. Perhaps I was tired or fatigued, or perhaps there was some sense of unfairness. Perhaps I needed something and couldn't get it. Perhaps it was just that kind of straw that broke the camel's back kind of idea, just a sequence of events, one thing after another. But there's usually a reason, right? It's we don't tend to experience really strong emotional reactions for no reason, and it's exactly the same after a brain injury. It's important for me to say that this isn't about excusing behaviour. I'm not saying that we should just kind of let people off the hook no matter what they do. Behaviour can still be unacceptable, but it's still important for us to understand what good reasons a person might have for showing us that behaviour and thinking about what that might be communicating. I think by doing that, it allows us to just wonder a little bit about how we might be able to offer a more compassionate response. So with that in mind, it's worth thinking about what kinds of needs drive behaviour. Some of the common ones that we see after brain injury are on the slide. People often struggle because they aren't getting enough connection or social attention from people. As a result, they might be bored, they might be lonely, they might be isolated. That, as you can imagine, often contributes to people feeling really distressed. If a person is in a hospital bed, in the dark, on their own, feeling alone, feeling scared, feeling frightened, and they find that when they do something that gets a response from staff, they feel a bit better, they're much more likely to keep doing it. So thinking about, okay, how can we provide that social attention, that connection? Similarly, escaping or avoiding something that's unpleasant. If something's painful or uncomfortable, somebody's naturally going to do things to try and pull away from it. We all would, so it's thinking, okay, what needs might be driving these behaviours? There might be some tangible or practical need. Somebody might just need the window opening because they're too hot. Somebody might need a drink because they're thirsty. There might be very concrete, tangible things the person needs, but they're not able to easily communicate that. And as I mentioned earlier, sometimes the sensory processing can be affected after brain injury. Somebody might find that the brightness of a room is really, really affecting them, but they can't easily explain that. But that's what's contributing to them feeling overwhelmed. So again, sorry, a bit of a whistle stop to all this, but something that we talk about a lot in the session that we run, the longer training session that we run around supporting people with behaviours that challenge, is thinking about positive reinforcement-based approaches. A big emphasis there is on understanding the behaviour in the first place, but then thinking about how can we respond to that in a compassionate way. Fundamentally, that is about reducing the need for the behaviour. So if somebody is shouting in a hospital bed because they're lonely, well, then let's make sure we give them more attention, then they won't need to shout as much. By thinking about how we might be able to facilitate them being able to get that attention or social connection, that might be giving them a call bell, finding other ways for them to communicate with staff. They don't need to do that behaviour that causes us challenge anymore. By showing or teaching a person more ways to get their needs met, we can have a really positive impact on their rehabilitation. Of course, that's not going to be easy. It sounds simple when I say it on a slide, but that might take years. That's going to take practice. It's going to take consistency. Fundamentally, though, I guess what we want to kind of really highlight is that these behaviours are complex. Some of it is driven by emotional factors, but also after brain injury, the very systems that allow us to calm down and regulate our emotional responses to situations might not work as well. Our ability to stop and think is driven by lots of systems all working together in tandem, and brain injury might affect either one of those areas in our brain, or it might affect the whole network. So behaviours that previously we may have been able to slow down and regulate now might be much more difficult. I think I often, when I'm working clinically with people, use the analogy of a Ferrari with no brakes, because that's what it can feel like often living with a brain injury. Instead of something that might have just been a bit of an annoyance, now a person goes from up to 100, it's really angry really, really quickly. And that still doesn't come from nowhere, though. I think this is something that really frustrates me. I think clinically, if I'm working with somebody and a team is saying, oh, they just get angry out of nowhere, I often challenge that, because I think, well, it comes from somewhere. There is something that triggers it. There is some process of that rising and escalating. It just might be quicker than it was before the brain injury. Brain injury might mean that this graph goes up more steeply, goes up more quickly. A person might go from being agitated to aggressive or even violent. They might get to that crisis point much more quickly than someone without a brain injury. But there's still signs that we can watch out for, and that's about getting to know the person, really making sure that we're tuned into what kinds of triggers might exist for the person, what things might be difficult for them, and then thinking about how we can intervene in a useful way. And often the kinds of plans that we put together really put the emphasis on that proactive approach. Sure, there's things that we might need to do in that crisis management phase, but really that's just about trying to keep people safe. It might be about giving the person a bit of space and time to calm down. Physical restraint is an absolute last resort. It shouldn't be the default response for anyone. But we're never going to really change the behaviour by focusing on that crisis management stuff. The good stuff, the thing that will actually make a difference, is being proactive. The times when the person is feeling calmer, that might be when we can talk about it. That might be when we help the person to learn new skills to help them to manage difficult situations. That might be where we have conversations about what was it that triggered that angry response. Was it being confronted with something that's much more difficult for you now? Is it about thinking then about when we can change the environment, or what we can do to understand those needs and ultimately communicate better? Of course, we also need a bit of a plan for what do we do if those warning signs of escalation do happen, making sure that, again, everyone's on the same page, that there's good communication about that, whether we're talking about within a family or within a staff team, making sure that we all know what to do if we spot the person starting to feel a bit more upset or a bit more threatened or a bit more angry, what do we do? How do we manage that? How do we help provide that bit of comfort and reassurance to help that de-escalation? And hopefully the long-term goal should be that we don't need the crisis plan, because I think we've helped by being proactive enough. We've helped it get to that point. And again, that's not going to happen overnight. That could take a really long time. Again, sorry for this being a slight whistle-stop tour, but I just wanted to mention as well very quickly about the idea of interactions between people, because we've talked a little bit about some of the factors to do with the individual. We've talked a little bit about some of the factors to do with the environment. I think a key part of the environment is the relationships with the people around them. And I think, unfortunately, something we see a lot in practice is that if somebody does experience some kind of problem with perhaps anger or aggression or other kinds of behaviours that challenge, the staff teams often pull away. They often struggle to get to know the person in the same way. It's harder to have positive relationships when somebody's really challenging to work with. And I think that's understandable, but it often becomes a bit of a vicious cycle then. If somebody experiences really strong emotions and then it engages or shows some kind of challenging behaviour, and then the staff team are less able to feel like they understand the person because they spend less time with them, then that person is going to feel even more frustrated, even more lonely, potentially even less well understood, and it's just going to keep escalating and escalating. So again, I don't have any quick fixes for that, but I think ultimately it's about empathy, right? It's about, no matter what kind of behaviour we're seeing, no matter how challenging that is, being able to think about our own response to that is critical. Being able to think about trying to understand what it might be like to live in that person's shoes, especially if they're living with a very severe brain injury and aren't able to communicate what that experience is like. Being able to appreciate them as human beings in a non-judgmental way, and just being able to think about some of the feelings that might be going on, even if we don't necessarily see something as anxiety or as loneliness or as distress. If it just comes out as anger, it can be really hard to reframe that, but understanding that this might be driven by other emotions can be really helpful. So I'm rapidly running out of time, so I'm going to just bring it to a close, just with a couple of take-home messages. And fundamentally, it's just that any behaviours that we might see, that we might experience as being challenging, is more often than not some way of communicating something. We often have to just work a little bit harder to think about how can we understand what that message is, and think about what the good reasons might be for why that behaviour might be happening or why it might have developed over time. And that might be really complex, and that might be something that needs kind of specialist input. It might be that you involve some sort of psychologist like myself or other kinds of health professionals to try and help you make sense of that. But fundamentally, that there shouldn't be any kind of behaviour that we just write off as the person being difficult or challenging. There's always a reason, there's always things that are driving those kinds of behaviours, and those cycles that can develop over time often can be supported. We might not necessarily resolve everything, but we can definitely generally make improvements to people's lives. So that's it for me. So I'm going to hand back over to